So it's my pleasure now to introduce Keiko Oda. Keiko is going to be talking about integrating oral health care into nursing practice. Keiko is a registered nurse with over 10 years experience in geriatric nursing. She completed a master's in health science that included research on oral care in hospitals and recently completed a doctoral research program in the School of Nursing at the University of Auckland. Congratulations. Keiko's research is to disseminate the idea that oral care is a key intervention to prevent deconditioning among care-dependent older people in the community so that nursing staff and residents can see the potential of oral care to protect the dignity and wellness of these older adults and are motivated to promote interprofessional collaborations that improve oral care delivery.
Okay, kia ora koutou. My name is Keiko Oda. Thank you so much for your introduction of me. So I'm Keiko, registered nurse and clinical educator. I'm gonna be clinical educator from next month in one of the aged care facility in Auckland. Okay, today's my topic is pretty much what I did in PhD, and then pretty much I'm doing at the moment as a research fellow in Auckland University. So nursing oral health assessment and care training is my project throughout my PhD and postdoc project with CHC funding. So some of the collaborators Ruth might be in the room. So thank you very much for your support. Firstly, my topic is generated from my own nursing practice in Te Whatu Ora Waitemata. I was working as a champion nurse to try to prevent patient falls in hospital setting. To prevent falls, we have to really look at what we could do as a nurse, and then one potential intervention we don't really do very well so far was oral care. Then I stick with my research topic since then 2016 and up to today. I come up with this hypothesis as a nurse. Oral care has 3 points to address for older people's deconditioning circle. So many of older adults in hospital setting having a problem with swallowing because of declined health condition as well as cognition. Maybe some people are kept nearby mouth in hospital setting. So dysphagia is progressing in hospital setting. And those people waiting for procedure nearby mouth prolonged sarcopenia further progress. People losing muscle tone, muscle mass, and then people likely to get aspiration pneumonia in hospital setting. So once you get aspiration pneumonia, you're further affecting your swallowing, so not be able to swallowing, dysphagia further exacerbating, sarcopenia progress. So this is bidirectional vicious circle. So oral care, if you press enter, please. If you put oral care into nursing practice, we can address these 3 components. One, by doing oral care, we can restore hygiene. And secondly, by doing oral care, people are likely to secrete saliva and also utilize muscle, oral muscle. So oral rehabilitation can be possible. So oral care has a potential for 2, restore hygiene and secondary rehabilitation. So I started to work in nursing oral care in hospital setting. And then internationally, oral care has a result as well. So in NHS, this is British data. So in hospital setting, the nurses integrate oral care into a daily care practice. We can reduce 70% of aspiration pneumonia and the usage of antibiotics and X-ray fee. So it's really cost reduction as well as better prognosis of older people in hospital setting. So, but in New Zealand setting, older people having a kind of worse oral health status because of, I think, accessibility, and traditionally people are removing teeth in these cohort, like people are older than 65-year-old. 30% of older New Zealand having a total denture or no teeth. So this condition is really exacerbated by resource And also nurses are not really actively working on oral health care in primary to hospital setting. So this is a problem I think I find in New Zealand data. So as a biggest cohort of health professional, if nurse including oral care into daily practice, we can improve other people's oral health outcome by individualized evidence-based nursing oral care delivery. This is my target for PhD. And the first step was identify current barrier. So please, next slide. So next slide, please. So 5 issue in terms of older people, New Zealand older people's oral health problem is basically if you are care dependent people if you live in aged care facility, 50% of people having a dysphagia, and those people dysphagia having a worse oral health. And dental service access is worsening for people who are community living, but much worse in aged care residential home for Pakeha. But in terms of Maori or Pacifica population, if people living in community, 3 times fewer access to a dentistry. But if residential home, older people, older Maori or older Pacifica, 2 times fewer access to dentistry. So basically 25% of community living, most deprived area of older Maori having a problem of chewing because of no denture or not fitting denture. This is really issue. And then 4th point is we nurses are not trained how to look at people's mouths, how to do oral care, how to make judgment of oral health assessment. So this is a big gap. And during COVID time, I also witnessed many older people in aged care couldn't really receive oral care because of its high infection issue as well. And then end of oral care, end of life, oral health is deteriorating, that we know of. So conclusion, basically as a nurse, please press enter. Sorry, this is really opportunity for us to do some basic oral care with dental hygienists, on-site education, on-site collaboration, and we can produce locally approved oral health guidelines together. This was the first next step of my PhD. So we worked together with dental hygienists and dentists. 5 dentists and 1 dental hygienist worked together with me to develop guidelines. That is a next step of my PhD. So these are the wonderful people I worked throughout my PhD. So 5 dentists and 1 dental hygienist. So we worked with nursing staff and older people, participatory action research to improve nursing care from 2020 to 2023, try to improve nursing knowledge and self-efficacy confidence in oral care delivery with evidence-based guideline and interprofessional collaboration education between nurses and dentistry. So what we achieve is establish IPCIPE with community nursing as well as aged care nursing staff. And based on our collaboration, we developed training protocol that we call Oral Health Care Planning, OCAP. And then we tested effectiveness of interprofessional collaboration education and our protocol. So this is basically research protocol, everything in this paper. So first study is community nursing staff. 14 nursing staff was attending our theoretical session. And then we measure baseline knowledge, self-efficacy, confidence in oral health care delivery. And after training, we measure post-training survey, same things. So we measure knowledge level, and we also measure self-efficacy and confidence in oral health practice. So self-efficacy and confidence is lower the better outcome. As a result of knowledge is increased, some statistical significance. However, confidence, self-efficacy, lower the better. So we like to see right side down line, but it's not significant. So I asked the nursing staff what we could do better is basically they said, we like to know how to do oral health assessment. We need to do hands-on assessment training. So this is a result I produced in paper last year, September, and many some Canadian nursing staff asked me to utilize this protocol as well. Next step is I identified current training is deficit because of we didn't do hands-on oral health assessment training. So I really focusing on how to do oral health assessment. So we produced oral health assessment training that we call NOHAT, Nursing Oral Health Assessment Training, putting the mouse into head-to-toe assessment. So nursing students doing oral health assessment hands-on under the supervision of oral health therapist. And we also revised how to look at oral health by simplified oral health assessment tool. So based on two components, hands-on direct supervision of oral health therapist performing oral health assessment, and the assessment tool is simplified. And as a result, so nursing students, Auckland University, 12 people are attended, and then all the students improving their confidence to do oral health assessment. And then we like to replicate same result with actual nursing staff in aged residential care homes. So it could replicate same result. Every single person improves self-efficacy, confidence in oral health assessment. So this is an article I produced in Journal of Nursing Education. So last step is we have to sustain normalized nursing oral health care practice by developing champion. Champion can train as a nursing staff so that we can sustain nursing oral health care practice. So developing champion was the last stage of my PhD. So this champion nurse is doing assessment of oral health status of this residents. So that time she find out this resident got the candidiasis. You can see creamy coat of the tongue. And then based on this result, we develop oral care plan for this gentleman, and they continue to do oral care and assessment. When I assess him 6 months later, his oral condition is much better. So he improved a lot. So they maintain good oral care for this resident. So summary to date is basically I established IPC, IPE to co-develop guideline and effective training module NOHAT. This is really good for nursing staff to improve knowledge and as well as skill to look at oral health outcome of older people. And inclusion of oral health component is important for nursing students to do oral care as well. And then I couldn't really get clinical outcome because of the time was issue to finish the project. So I like to look at more clinical outcome in aged care residential home so that we can roll out this initiative wider community and generate better clinical evidence so that we can influence policymakers as well. So currently I'm working with Christian Heart Trust postdoc research project. So at the moment, I worked with 3 residential care homes. Last 2 weeks, I did same intervention, theoretical training first, try to increase knowledge and self-efficacy of oral health care of older adults in 2 residential care homes so far I've done it. So these are demographic data of nursing staff in 2 aged care facilities. So majority is basically migrant nurses, Indian, Filipino, and other is no Pakeha, probably more Brazilian or other country, other rest of other countries trained nursing staff. Most of the participants is middle age, and quite surprisingly, it's quite different from Wellington site. Bachelor degree, higher than bachelor degree is a predominant. So that is quite interesting democratic data of the people participants. So far, I just did survey to measure knowledge level and self-efficacy of oral health care, and a pre and post theoretical training survey. It's already showing some good result as well. Knowledge base is improving, and then as well as self-efficacy, self-confidence on doing oral health assessment as well. So people are really appreciating doing this initiative, and then nursing staff, healthcare assistant is really engaging well. So hopefully 6 months time, we can get more positive clinical data from other people's oral health outcome throughout my initiative with nursing staff in aged care facility. Thank you very much for having me. Thank you so much for your time.
So questions from the room? An online question, good.
Keiko, do you think we'll be looking at building, renovating ARC homes in the future to include dental chairs, equipment and training for nurses in ARC to improve access of older people in residential care?
Thank you for your comment. So my idea, my target is if I can continuously to get good result in terms of nursing staff confidence, self-efficacy to doing oral health care and getting more clinical outcome. Maybe maintenance of oral health is good enough, probably for older people. We are expecting, because of end of life, rapid oral health deterioration can happen. But if we maintain basic oral health care, maybe we can still achieve maintenance of oral health status of older people. So based on our probably research outcome, maybe if we can get better outcome, maybe we can gain more nursing champion from my training, so that we can do more training, wider roll out of our research, initiative. So I think eventually the many champions can disseminate our knowledge as well. So this is one of the opportunity for me is presenting conference and talk about this research, and then people are get interested in and work together, and we can develop more champion in aged care residential home as well as nursing student champion, so we can pollinate idea to wider clinical setting. That's my idea as well. Thank you.
Any other questions, Simone?
Hi, just a question about your clinical outcomes. You mentioned at the top of your presentation about the link between oral health and aspiration pneumonia, and we know already that swallowing impairment is only the third indicator for aspiration pneumonia after oral health. The first one on dependency of feeding being the second one. So just wondering whether in your clinical outcomes you'll be measuring incidence of aspiration pneumonia in the aged care facilities?
Thank you for your question. Aspiration pneumonia, maybe by doing oral care, basic oral care, and the most safest oral care, if we do it, probably occurrence of aspiration pneumonia should be decreased. But from the American Zimmerman's group, they did huge randomized control trial in 2020, just before COVID time. So 1 year time, they improved, decrease occurrence of aspiration pneumonia for aged care residents, statistically significant. But 3 years time, the reduction is not statistically significant. So it's really hard to probably measure is one thing. People are end of life, many people are getting pneumonia, but aspiration pneumonia, we don't really clearly differentiate. But if people are older than 80-year-old or 90-year-old, pneumonia, 90% of the time, aspiration pneumonia, we know from the clinical data. But I think we can reduce probably aspiration pneumonia if we integrate it into oral care, basic nursing care. But I don't know in aged care residential home. In hospital setting, there is a data, but aged care facility, especially end of life, I don't know.
Linda, you have a question.
Yeah, thanks. Really interesting research, actually. I'm just wondering whether you looked at just clinical nurses, so trained nurses, or whether you looked at the whole staff within aged care facilities to train them up for oral care.
Thank you for your question. I believe the most important thing is healthcare assistant to be confident and willing to look at people's mouths and helping people's oral health care with the idea of person-centered care. So all the people's preference is most important as well. And the clinical guidance we can get, standardization of oral care for this dentate patient, residents. So my focus is firstly champion development and champion work with healthcare assistant, wellness partner, and they influence each other and a safe oral healthcare delivery to think together and person-centered oral care to deliver. That's what we try to aim for this project. But to be honest, I think what we could do is probably oral cleanliness we can achieve. So less food particle, food residue on the mouth, or less plaque. So I'm really looking at less plaque in the mouth, food residue is reduced, good oral cleanliness. That's I'm looking at for this project, for clinical outcome.
So, Keiko, interesting topic. I have had some thoughts. You might not be aware that the new version 10 of the interRAI long-term care facilities assessment has increased items related to oral health. And so those items look to me, without just doing a mental look, pretty similar to some of your, what was not before the no-hat, what was the oral health assessment. So it might be that the training program that you have developed for the no-hat would be good to be collaborating with the interRAI training service, because they're going to have to incorporate into the new training these improved ways of managing these new items. And so there's an opportunity there. And then there's another opportunity where if you're wanting to look at outcomes, with age residential care people being reassessed every 6 months, if you have taught, say, a care home your training, and they've had interRAI training that includes a more focused look at oral care, you'll be able to see, using the interRAI data, the effect of what is the outcome for those older people. So I think there's plenty of work to be done. And I'm glad you put your hand up for it.